We're going to speak a little bit today about alternatives to surgery for the treatment of uterine fibroids. Unfortunately, Dr. Koch could not make it to be with us today. She sends her apologies. Okay, let's just start here. We have a couple of slides we're going to go through first. Okay, so what are uterine fibroids? So uterine fibroids are small benign tumors that grow within the uterus. They can originate as a single growth or in clusters. They're unlike cancerous tumors, they rarely split to other organs in the body. And here we have a picture on this slide of a uterus, which shows that this is actually, if you can see, this is the uterus. There's the lining of the uterus. So the fibroids here's the cervix. The fibroids can occur in different parts of the uterus. You see the one I'm pointing to here is a submucosal fibroid. So it's right underneath the inner lining of the uterus. There's another one here. It's called a pedunculated submucosal fibroid. This is actually in the cavity of the uterus. And you can imagine if this little stalk here gets cut off, this can actually pass through the uterus and out of the body. Most fibroids do not do that. The most common fibroid is what's called an intramural fibroid. It's in the muscle layer of the uterus. And then there's something called a subserosal fibroid. This is in the outer layer of the uterus. So fibroids come in many different sizes, even in the same patient. You may have different locations for the fibroids and different sizes of the fibroids. Okay, again, here's just showing a pictorial representation of an actual, of a uterus. Again, showing some fibroids. Here's the inner lining of the uterus. There's actually, remember, so when a woman has her menstrual period, so there's sloughing of the lining of the uterus, and then leads to menstruation. Here's the cervix, and here's the vagina. The uterus is connected to the fallopian tube. So when here's the ovaries, and where there's ovulation, the eggs will go into the ovaries, and then go into the uterine cavity, and that's where the baby would grow if it's fertilized. Okay, so what are the risk factors for uterine fibroids? They include genetic changes. Many patients have a strong family history of fibroids. There are certain groups that have very high incidence of fibroids. For example, Black women may have up to 80% chance of having fibroids at some point in their lives. And if their mother or grandmother had fibroids, they have almost a 99% chance of developing fibroids also. Hormonal changes include hormonal imbalances, lifestyle choices, including poor diet, eating a lot of red meat, drinking alcohol or caffeine, or not drinking enough water may contribute to fibroid development, and obesity. What are the symptoms of uterine fibroids? So they may present with heavy menstrual bleeding, very commonly, and this is actually very common in the 40 to 50-year-old age group. Patients may have been symptomatic, having normal periods before, and then they start developing heavy menstrual bleeding, particularly within the first days of the menstruation and continuing possibly for even several days afterwards. Some patients with fibroids also develop spotting in between periods. They may develop such severe bleeding that it affects their lifestyle. And we'll talk a little bit about that later. You may get intense pelvic cramping. You may also get pelvic pressure or pain, particularly if the fibroids are pushing on other organs in that location. So the areas, the uterus is very close to the bladder. It can push on the spine. It can push on the upper abdomen. So those areas can be affected by the fibroids. You may, since it can push on the bladder, you may develop frequency of urination, have to go to the bathroom frequently. You may get low energy and feel very tired. All these things, sometimes you have severe back pain associated with menstruation. So what is a uterine fibroid embolization? So there are many treatments for uterine fibroids. Surgical treatments are well known to many of you. First of all, a hysterectomy. If you're after menopause and you still have symptomatic fibroids, the gynecologist may recommend performing a hysterectomy. That's just removing the entire uterus. If If a person still wants to have children, then they can, the surgical option would be myomectomy, which means actually opening up the uterus and taking out each fibroid. Most of the time, they won't take out all the fibroids, but just the larger ones. And what we do is a non-invasive procedure. There's not surgery. Basically, we're attacking the fibroids internally. The fibroids, and here's a picture of a fibroid inside the uterus. And fibroids tend to have a very, very brisk vascular supply. They need a lot of blood flow to live, more than the rest of the uterus. So they tend to try to suck up a lot of blood from the blood vessels that feed the uterus. So by attacking them directly through the blood vessels and injecting particles, which you see here, this is called an embosphere microsphere. These are tiny, tiny particles which are directed into the blood vessel supplying the fibroid. And when you knock off the blood supply to the fibroids, you effectively kill the fibroids. And that's the whole idea behind a uterine artery embolization. So a catheter is inserted into the groin artery, usually under fluoroscopic guidance, so it's a tiny little puncture hole. The catheter is threaded under the X-ray into the blood vessel supplying the fibroids, and then these tiny little microspheres are injected into the blood vessels to basically kill the fibroid. This is actually, we've been doing this for about 20 years, thousands of cases, a very safe procedure, and most of the time we have excellent results. We'll talk about that in a minute. Certain patients are not candidates for the fibroid embolization. This is actually an MRI examination of a uterus. So I'm going to just, with my pointer, I'm going to show you, this is the extent of the uterus here. The normal uterus is just something like this round ball. And here's your cervix, and the vagina would be down here. This is your spine in the back. So you're actually cutting the person from the side. Here's the abdominal wall, and here's the back. So this whole big mass here is one giant fibroid. This is called a pedunculated subserosal fibroid. And there's actually here, there's another fibroid. This other glob here is another fibroid. It's called a submucosal fibroid because here's the uterine lining. It's actually pushing the uterine lining backwards. So this patient will probably have symptoms of bulk symptoms. She's probably feeling that she feels bloated, and she feels that there's a mass growing in her stomach and in her pelvis. But also she may have some bleeding symptoms because of the submucosal fibroid. And that's not just the only one. So there's another one here, another small one here, and so on. So when you have these very large pedunculated fibroids, this may actually not be such a great candidate for fibroid embolization. It's an easily taken care of surgically with laparoscopic surgery. The surgeon goes in and basically cuts this off, and it's a very easy surgery. Now we can do this with fibroid embolization, but we may not be able to shrink it as much as the woman would like. Also, if there's a submucosal fibroid, which is very large, then there's a chance that it may cause problems later. So in general, we won't treat those patients. Okay, again, here's just a pictorial representation of the fibroid embolization procedure. So the catheter is introduced through the blood vessel in the groin after it's numbed up. And here the catheter is directed right into the blood vessel supplying the fibroid, and the particles are injected into the blood vessel supplying the fibroid, leaving the uterus intact. And it's done on both sides of the uterus, on the right and the left. And usually it takes about 45 minutes, about a 45-minute procedure in general. This is another pictorial representation. So most of the time we'll puncture the artery in the groin and go to the uterine arteries, but now we can actually go from the arm and advance it into the blood vessel supplying the fibroid in the uterus. And this sometimes is a little bit better because the patients can actually move around after the procedure because they don't have a groin puncture. In general, if you have a groin puncture, you may not be able to sit up for about an hour after the procedure. But if you're going from the arm, then you may be able to sit up right away after the procedure. Again, this is just some new developments in the technique of the procedure. So let's give you a little bit of data. So the technical success rate for fibroid embolization procedures over 97%. Excellent, really excellent technical success. If patients present with bleeding symptoms, then about 93 to 98% of the time, they're going to get those symptoms are going to resolve following the procedure. Improvement in bulk symptoms, in other words, if a patient comes only with symptoms of enlarging mass and feeling bloated and so on, about 80 to 86% of the time they'll have resolution of symptoms after this procedure. And the reason why is that when the shrinkage in uterine volume is about 40 to 50% at 9 months. In other words, the uterus is not going to completely shrink to zero. You'll get about 50% shrinkage of the uterine volume from this procedure. So if your symptom is just that your stomach looks bad and it's a cosmetic situation, then this is really not a good procedure for you. But if you do have the symptoms that we talked about, particularly heavy bleeding, frequency of urination, back pain, pelvic cramping, then you would be a good candidate for the fibroid embolization procedure. Okay, so again, just to show these points in a bullet format. So who are the patients who are good candidates for fibroid embolization? So most patients with symptomatic fibroids, I would say at least 90% of patients that we see with symptomatic fibroids are good candidates for the embolization procedure. Patients with symptomatic fibroids are not pregnant. Obviously, if a patient is pregnant, they're not a candidate for the procedure. If the patient wants to become pregnant and is already over 40, then we may not want to do this procedure on them because it may decrease the fertility in this patient. In other words, by doing the procedure, the chances of fertility may go down. And in a patient who's over 40, the fertility, in other words, the fertility is significantly less than younger patient. So we may not want to jeopardize that fertility by doing this procedure. In general, just to note that the surgical procedures will also affect fertility. So it's not just only for the fibroid embolization procedure we're talking about this. Patients wishing to avoid surgery or long recovery. We'll talk about that in a second, but in general, patients who undergo the fibroid embolization procedure, the procedure is done in an outpatient setting. Patients not stay in the hospital, and they're usually home for about a week or two after the procedure. As opposed to surgery, patient may require, depending on the type of hysterectomy or myomectomy that's done, patient may have to stay in the hospital for up to a week, and the recovery is usually about 2 months following the surgery. Patients desiring uterine preservation. If you want to keep your uterus and not take it out, then obviously be a good choice for that patient, because you could save the uterus while treating your symptoms. Perimenopausal patients, patients who are close to menopause, actually ideal for the embolization procedure because they'll probably be going into menopause anyway. In general, after menopause, fibroids tend to shrink on their own because the blood supply gets less, the hormones change. So perimenopausal patients are excellent patients for fibroid embolization. Patients who are poor surgical candidates, if they have anemia, if they're anticoagulated and so on, if there's a problem with them undergoing surgery, then clearly the fibroid embolization procedure is a great procedure. Patients who do not desire future fertility. Again, we mentioned that in general, if you're very adamant about trying to have kids, and particularly if you're over 40, then this may not be the right procedure for you because it may jeopardize future fertility. Patients with hysterectomy, HRT concerns. Okay. This is just a comparison slide comparing fibroid embolization, which is UFE, hysterectomy, and myomectomy. In general, UFE, nowadays, there should be no hospital stay. For hysterectomy, average 2.3 days, myomectomy 2.5 days. Return to work, average 10.7 days, hysterectomy 32.5 days, myomectomy 37 days. Complications higher with surgery, obviously, and major complications significantly higher with surgery. Okay, I'm just going to show one quick case of mine, a very typical case of a patient with fibroids. So this patient was a 37-year-old female, 37-year-old woman who was premenopausal, history of uterine fibroids, who presents with iron deficiency anemia, meaning she's bleeding so heavily from the fibroids that she now has anemia. And actually, hemoglobin level was 6.3. The normal hemoglobin level in her would have been over 13. So she's lost already half of her blood, and she's pretty symptomatic. So when you have anemia, you may get tired very easily, may have fainting episodes, and so on. And it was all from this bleeding from the heavy menstruation. Heavy menstrual bleeding, lower abdominal pain and cramping, and frequency of urination. She stated that she bleeds so severely that at the beginning of her menstrual period, that she sometimes has to wear a diaper, and she can't leave the house for 2 days because she's bleeding so much. She has been taking iron supplements, but her hemoglobin level is still very low. And she was initially treated with something called Lupron therapy. Some patients were also treated with birth control pills, but it really didn't help her symptoms. And patient had an MRI examination of the pelvis, which demonstrated that she had multiple fibroids throughout the uterus. Again, I just wanted to show you what an MRI looks like. And here's an MRI. It's called a sagittal view, because here we're looking again, here's the back of the patient and here's the front of the patient. So here's the abdominal muscles, here's the spine, and here is this very large uterus, which is filled with fibroids. So there's a fibroid in the uterine cavity itself. There's a big fibroid submucosal. There's another fibroid here, here, here. And if you look at a different view now, another fibroid, there's a separate fibroid in the upper part of the cavity, a fibroid here. So they have multiple fibroids throughout this uterus. And this is on this slide, this is actually a cross-sectional view. It's a little bit of a different view. So it's cutting the patient up to down. So this is just, here's the front of the patient, here's the back of the patient. And again, seeing big fibroids in the uterus right around here. So this patient came to us for evaluation for the fibroid embolization procedure, and we did deem her a good candidate for the embolization procedure. This is called an angiogram, and actually you can see, so you can imagine we're coming from the opposite groin, and there's this little catheter, which is a tiny tube going directly into the blood vessel supplying the fibroid. This is called the uterine artery, and I don't know if you can see it here, but in fact, this is a better view. You can see this is actually a giant fibroid. Where you see this blush of the dye inside the uterus. This is a giant fibroid inside the uterus. So we were able to get a catheter further in, and we injected these tiny little particles which block up the fibroid blood vessels. And then we did it on the other hairs, and you can actually see this is on the left side, and here actually is another one on the right side. We went into this, and by the end, you just see a blob of dye that stays in the uterus because there's no blood flow. And basically, we're trying to kill the fibroids from the inside. And the procedure was successful. So this was actually, we did this procedure on this patient several weeks ago. Patients are usually seen 2 weeks after the procedure. So following the procedure, most patients will have some cramping within the pelvis. It's well treated with pain medication. We do give you some pain medication after the procedure for several days. You may have some loss of appetite for a couple of days. You will have some spotting for up to 3 months following the procedure. But in general, the symptoms are self-limited and they improve each day. Most of the time, patients return to work about 10 days to 2 weeks following the procedure. And this patient came back for follow-up. Already her bleeding symptoms were almost completely resolved. She was a little constipated, but she otherwise was doing great. She felt flatter in her stomach, and she was just so thankful after the procedure. So within 2 weeks after the procedure, she was already feeling great. Okay, so let's just summarize. Uterine fibroid embolization is a proven effective method to treat symptomatic uterine fibroids. About 30,000 of these procedures are performed annually in the United States. As we said, between 80 to 95% clinical success, a little bit better for bleeding symptoms and a little bit less for bulk-related symptoms. Clinical studies show equivalent symptom relief compared to surgery with less recovery time and complications. As we said, it's minimally invasive, meaning there's no incision here. It's a tiny puncture hole, and you're out of the procedure in an hour, and usually out of the facility within a couple of hours after the procedure. Again, as we said, outpatient service for most. When we started doing this, when I first started doing this procedure, I would only do it in the hospital. But we've done so well with it and we find that patients tolerate it very well in an outpatient setting. Patients just have to stay in the office, in the surgery center for about 2 hours after the procedure and then can go home. As we said, patients return to normal activity in about 1 to 2 weeks and has a very low complication rate. Okay, and this is just a slide of our facilities. I work in the Lower Manhattan facility, but we do have facilities in Queens and Fishkill and in New Jersey. Okay, if anybody has any questions, please ask the questions on the Q&A, and I will try to answer it. Okay, I have a question that came up. Okay. Does UFE only work for fibroids that are outside the uterus, or does it work for submucosal fibroids? Right. So that's excellent question. No, uterine fibroid embolization works for all fibroids in the uterus. The only question is if you have a submucosal fibroid that's too large, what can happen? In general, the fibroids do not come out. Once this procedure is done, they stay in the uterus and they shrink internally. The body eats them up, basically, and scars them down. So if you do an MRI of a fibroid after the procedure, in the beginning, they'll look a certain way. And afterwards, since there's no blood flow, they'll turn black. You won't see them. So they'll scar down. The issue is when you have very large, in very rare cases, less than 10% of cases, if you have a submucosal fibroid that's very close to the lining of the uterus, it can die and then actually slough, which means that it can come out. It can actually pass through the lining and come out through the vagina, which again, this is very rare for this to occur and actually can occur spontaneously in some patients. Some patients have this phenomena occur naturally without the fibroid embolization procedure. In general, if the fibroid is small, then it's no problem. It'll just pass right out, just like a clot of blood. It'll pass out like a tiny piece of tissue. But if it's very large, if it's greater than 7 centimeters, then it can sometimes get stuck in the uterus, and you have to pull it out surgically. The gynecologist may have to put a clamp in there and actually tease it out. So in general, if the fibroid is greater than 7 centimeters and is in a submucosal location, it may not be a good candidate for the embolization procedure. And that's why we do MRIs beforehand to look at all the fibroids and see where they're located and see if they're amenable to treatment. So again, and then the second part of the question was, so again, the fibroid embolization procedure will work for all types of fibroids, submucosal, subserosal, and intramural. The issue is if you have very large submucosal fibroids or if you have very large subserosal fibroids, they may be better treated surgically. You can treat them with UFE, but you may not get a good result as with surgery. Okay, second question, when would you recommend UFE or myomectomy? So again, if a patient really wants to have another child and they're over 40, I would probably tell them not to have the fibroid embolization procedure, because by having the embolization procedure, it may decrease their fertility. So the data is about, in patients over 40, about 2% of the patients will develop early onset menopause after this procedure, so 1 to 2%. So it's not much, but it is a possibility. So if you're really intent on having a child after 40, this may not be the right procedure for you. In general, if you're under 40, the chances of you decreasing fertility, having a problem with fertility at that age is very low. So actually, if you're under 30, it may not be. If you're under 40, it may be a good procedure for you. In general, if a person wants to maintain fertility, we'll modify the procedure a little bit, call it something called Embolite. We won't do the full, embolization. We won't put as much particles in as we would have for somebody who doesn't care about fertility. And you may have some of the fibroids not completely killed, but you'll definitely not jeopardize fertility in that situation. So a myomectomy, if you have one isolated fibroid, and not multiple fibroids, then myomectomy may be a good option. Again, there's problems with myomectomy also. Number one, it causes scarring in the wall of the uterus, and you have a higher incidence of uterine rupture after myomectomy. It thins out the wall of the uterus, so it may be more difficult to carry the baby. And again, if you have to dig out multiple fibroids, it's really not a great procedure for you. But again, I recommend that everybody who's considering any of these treatments should get multiple opinions. Talk to the gynecologist, see what they recommend, talk to an interventional radiologist, see, and each person has to decide for themselves what the right procedure is for them. Again, it depends on fertility, it depends on if they want to have surgery, if they want to get the uterus out completely. There's a lot of different factors, but I recommend each person should get multiple opinions and do their own research. And we found that most of our patients come from the internet, in the sense that patients are looking for minimally invasive treatments. And this is, a tried and true procedure, which has been done for many, many years. And it works. And people who are doing their own research and seeking us on the internet will find that this is really a very safe and a viable procedure, and they can save their uterus, not undergo surgery, and still have a great result. So I encourage everybody to be as informed as possible about all the different procedures. Another question: is there any way to prevent getting fibroids? No, I wish there was. Wish there would be. In general, like we said, certain ethnic groups tend to have a higher incidence of developing fibroids, and it's very high incidence in patients who have a strong family history of fibroids. There's no way to really prevent it. And actually, another question that people ask is, if I do this procedure, can I still develop fibroids? Another excellent question. So in general, you have over 5 years, you have a 10 to 15% chance of developing new fibroids after the fibroids have been taken care of by the embolization procedure. Again, you're not taking away the propensity to develop the fibroids. All you do is killing the fibroids that are there. So in general, we say about 10 to 15% chance that you can develop new fibroids after this procedure within 5 years. Again, ideally, a lot of the patients that have symptomatic fibroids are in that 40 to 45-year-old age group, and most patients will be going on to menopause a couple of years after that. So actually, that's really the best patient for us in general, because then once you hit menopause, in general, the fibroids tend to shrink on their own because of the hormonal situation. Okay. Any other questions? Let's see. I think I went over the issue about let's talk a little bit about what happens after the procedure. So as I said, in general, patients can have some pelvic cramping after the procedure. That's well treated with medication. They may have, again, as I said, some loss of appetite for a couple of days. You're not going to feel great for a couple of days after this procedure, but compared to surgery, it's a different ballgame. Obviously, when you have incisions and so on, surgery is a lot more, then the recovery is a lot more difficult for patients who want to go surgery. What can I do after the procedure? So in general, you can resume normal activities within 2 weeks after the procedure. Go back to the gym, resume a normal diet, resume sexual activity, all that with probably about 2 weeks after the procedure. I usually tell patients that the menstrual periods won't normalize for about 3 months up to 3 months after the procedure, meaning that in general, if you have heavy bleeding, the heavy bleeding will stop. You'll just have spotting for several weeks after the procedure, but you may not resume normal cycles until about 3 months after the procedure. After that, you should resume normal periods. In general, I'll see the patients, as I said, 2 weeks after the procedure, and then probably 9 months to a year after the procedure. If they're still having symptoms after a year, then we may repeat the MRI and see if there's anything else going on. If a new fibroid has grown, rarely again, or is there something else going on with the ovary or with the fallopian tubes. So in general, that's when I see the patients. And as I said, most patients are extremely happy with the results. This patient who I told you couldn't leave her house for 2 days each month, she's already started to have a normal period. This is about a month after the procedure. Was able to go to work. She only had the bleeding with up to 2 or 3 pads for the entire day, and she was just very, very happy and satisfied with the results. Again, I think it's a great procedure. I've been doing it for many years, and I recommend it that if you do have these symptoms, you should definitely consider fibroid embolization. Okay, I don't think we have any other questions. Anybody else have any questions?
No, thank you so much, Dr. Shams.
Okay, great. Everybody have a great evening.